Good morning, everyone. We are just honored to partner with the Keck School of Medicine today. And this, again, is one of our Emeriti Center wellness events. And I would like to introduce Nadine Diaz, who will tell you a little bit more about what we're going to do today and introduce our esteemed speaker.
Great. Thank you, everyone, for joining us today at 10 o'clock in the morning. We truly appreciate your attendance and your interest in hearing Dr. Helena Chui, who is actually my boss, and she is the chair of the neurology department at USC. She is also in charge of the ADRC as an administrative co-lead at the Alzheimer's Disease Research Center, which has been at USC since 1984. It's a federally funded program, and your federal taxes actually pay us to conduct research. I have been with the center since 2007. I guess you can call me the alpha recruiter and retention coordinator. And Dr. Chui oversees the program and all the other cores that are involved. She is an expert and a leader in Alzheimer's disease research, and she is here today to talk about Alzheimer's disease research, current developments, and other topics that pertain to dementia and Alzheimer's disease. Thank you, Dr. Chui.
Thank you, Nadine, and thank you, Jeanette, and thanks to all of you for coming. I've been at USC almost 40 years now, and looking forward to joining your ranks, hopefully one day, as you are all distinguished emeriti. And I see many friends and colleagues here this morning. Let me share my screen and let me know if you're having trouble hearing me or seeing the slides. Great. Well, I'll go ahead and get started. It's an exciting time now in Alzheimer's research because the FDA approved what we hope is a disease-modifying treatment for Alzheimer's in June. We're not sure whether Medicare will pay yet, so we're still a little bit in a holding pattern. But I consider this a very exciting time, and we'll talk about that as number 4. I hope I'll leave enough time for you to ask your questions at the end. My outline is to just give a brief update on epidemiology, the population frequency of Alzheimer's and dementias, talk about our current conceptualization of the causal chain. It's still complicated, and it could be more than misfolded proteins. I'm sure it is, but I'm going to discuss that idea that neurodegenerative disorders basically represent an accumulation of misfolded proteins. Genetics play an important role in Alzheimer's, but it's complicated. There are many different genes, so it's polygenic. And I'll end with talking about the Alzheimer's research at the Keck School of Medicine. So emeriti kind of means maybe these years after age 65, after retirement, and these are the hurricane years for dementias across the whole world. Right now, we estimate there are 4 million people in the United States that have dementia, and the most common cause is Alzheimer's. And you see the curves here are very similar in Europe and in China, and that the curve goes up with age, doubling every 5 years. So it's estimated that there are 40 million persons with dementia worldwide. Dementia is a syndrome, a group of symptoms that are clustered around the word dementia. I think of as meaning a decline, D, and mentia meaning mental capacities, like memory, could be language, spatial abilities, concentration, executive functions. There are many causes for the syndrome of dementia, but the big white slice there is Alzheimer's disease, and the red slice is stroke-related dementias, and the big yellow piece of the pie are a mixture of Alzheimer's and strokes. But this still leaves important other causes of dementia, like Parkinson's disease here, frontotemporal lobar dementias, and certain things that are even treatable. So dementia by itself means a decline in mental abilities, but it does not necessarily mean irreversibility or not treatable. There are many, in fact, modifiable risk factors for a dementia as a syndrome. This is a review article published last year in The Lancet looking at our life course here, and different things at different stages of life that can contribute to increased risk of dementia. Less education contributes about 7% risk. This is in the formative years, and we're worried about our kids that couldn't go to school during the pandemic. For emeriti or people that have studied all their life, well, we don't really worry about the less education. But hearing loss in midlife can predispose to increased dementia risk. So can brain injury, high blood pressure, alcoholism, obesity. And then later in life, smoking, depression, social isolation, physical inactivity, air pollution, diabetes. So these modifiable risk factors contribute to about 40% of the dementia syndrome. So it's never too late, never too early, never too late to be ambitious about prevention. And these factors are important even for persons who have known genetic risk factors. Now, Alzheimer's is the most common cause of dementia in late life. And we name this disease after a German neurologist psychiatrist who followed a woman in her 50s who had a progressive dementia. And then after she passed away, he used a silver stain and described changes called plaques that he called plaques and tangles. We know now that plaques contain a misfolded protein called beta amyloid, and the plaque is located at the places where nerve cells talk to each other at the synapse, like coming together. And that the tangles that he saw picking up silver reflect accumulations of another misfolded protein called a tau, Greek alphabet tau, which normally stabilizes microtubules that form the cytoskeleton of the highways within the nerve cell that allow transportation of proteins from the cell body down the axon to the synapse, and also are responsible for the transport of proteins and nutrients to the branches of the neuronal tree. So the accumulation of plaques and tangles, or nowadays we say the accumulation of beta amyloid and phosphorylated tau proteins associated with a progressive dementia, is the definition of Alzheimer's disease. Now over here, you see Alzheimer's disease associated with two misfolded proteins, beta amyloid and a phosphorylated tau protein. And way over here, we see that the amyloid can come together, accumulate, aggregate as a plaque at the synapse. And the phosphorylated tau aggregates as a tangle inside the nerve cell. And yet the part that we think is toxic are the small monomers, one little protein, or oligomers, a few of these proteins, and not so much the aggregated state of the amyloid plaque and tangle that define the disease. So really, we believe our target ought to be these oligomers. Now we have made progress. We can measure beta amyloid and tau in cerebral spinal fluid, PET scans, and coming soon, it'll be much easier when we can measure these in blood. Now, when I see patients in the memory clinic at Keck, and my colleagues in the community, we order a CT scan or an MRI scan. That's shown on the left here. A CT or MRI can show the volume of the brain inside of the skull. And here would be brain filling up the intracranial cavity. And here, an MRI showing volume loss or atrophy of the brain throughout the brain, and including the medial temporal lobe, an area called the hippocampus, which is the memory center of the brain. But an CT or MRI cannot show us plaques or tangles. They cannot show us amyloid or tau. So we used to say that the diagnosis of Alzheimer's disease could only be certain at autopsy, when we could see the plaques and tangles that Dr. Alzheimer first described in 1907. But now the FDA has approved 2 types of PET scan for detecting amyloid and tau in living persons. This is an example of an amyloid PET scan, and the purple colors here show the deposition of amyloid in a living person. And here, the purple color is showing the accumulation of phosphorylated tau tangles in a living person. So we can now make the diagnosis of Alzheimer's disease in living persons. And hopefully soon, we'll be able to do it in blood. We can, as I mentioned, we already can measure these proteins in spinal fluid through an LP. Now, because we have these PET scans, there are studies following people living in the community with no memory problems, starting in their midlife and doing amyloid and tau PET scans. So here, let's say, is a person around 75, age going this way. And here we're starting to see the appearance of dementia. It starts kind of mild with problems with short-term memory, and then includes language, visual, spatial, and executive functions, and the dementia gets worse with time. But the amyloid PET scans are showing the accumulation of amyloid even 25 years, I usually like to say 15 to 20 years, several decades before the onset of clinical symptoms. And the tau PET scans start to become positive in between. Now, this is an important insight because it provides a potential window when, if we had a way to prevent amyloid or tau accumulation, we might be able to prevent Alzheimer's. It may, in fact, prove easier to prevent Alzheimer's someday than to treat the symptoms once they're fully developed, because at this time, amyloid and tau are widely spread throughout the brain. Now, I'm turning a little bit to genetic risk factors. I had a slide before talking about modifiable risk factors like hearing loss and depression and not enough education. This slide summarizes the genetic risk factors that we know about for Alzheimer's disease. And all these little circles here represent genes that increase the risk for Alzheimer's. On the x-axis here is the frequency of these genetic risk factors. And on the y-axis here is the strength of these deleterious effects. So there are a cluster of genes that are quite common, but they actually are not that strong in terms of their risk effect. And then on the opposite end here there are some rare genes that have a huge effect on Alzheimer's risk. And these are, in fact, autosomal dominant genes. Probably a gene like this affected Alzheimer's first patient who started to have symptoms in their 50s. And we are studying families who have autosomal dominant Alzheimer's disease and symptom onset in their 40s. There's a movie called Still Alice, where a professor on her 50th birthday is developing symptoms of memory loss and has in the movie presenilin 1 gene. Now in the middle of the field here, I wanted to point out the apolipoprotein E4 gene. Apolipoprotein E comes in 3 flavors, 4, 3, and 2. And the 4 type is associated with significant medium risk for Alzheimer's disease. If 1 copy is carried, the risk is double. And if a person is carrying 2 copies of ApoE4 from both parents, the risk of Alzheimer's is increased 10-fold. Here's some other genes that are not uncommon and have moderate effects. TREM2, for example, is a gene that modulates the activity of microglia, the scavengers of the brain that are important in cleaning up amyloid. So apolipoprotein E4 is the strongest and most common genetic risk factor for late onset Alzheimer's disease. 1 out of 4 people carry an ApoE4 gene. So that might be about 15% of us on this webinar. And carrying 1 ApoE4 gene doubles or even quadruples the risk of Alzheimer's. And having 2 copies of E4, 1 from each parent, increases the risk of Alzheimer's 10-fold. We're still looking for a specific way to reduce risk associated with the ApoE4 gene. Meanwhile, we're recommending regular aerobic exercise and a healthy Mediterranean diet with good omega-3 type healthy oils. This is a brief summary of what's been going on here. I came to USC in 1981, about 40 years ago. So I have kind of lived this. At the beginning, we started to have some acetylcholine esterase inhibitors. There's 3 that I prescribe in practice. And then we had an NMDA antagonist, 1 memantine, also prescribed in practice. These have been available, you can see here, for 40 years. Nothing too new. There have also been some medical foods like ketogenic diets that have been tried. And we've tried anti-inflammatories like non-steroidal medications, antioxidants like vitamin E. Here's fish oil. I mentioned omega-3 fatty acids, cholesterol-lowering drugs, hormone replacement therapies, and then things that can boost mitochondria. That's going on in the Andrus Gerontology Center. Hassie Cohen, the dean, is doing research there. And modifying amyloid and tau. Here's a snapshot at medications that are in clinical trials right now. Phase 1, we're just looking for understanding the pharmacokinetics phase 2 doing some dose escalations, and then phase 2 and 3 starting to test whether the medications actually have a beneficial effect on memory and cognition. And then after there are 2 phase 3 studies that are positive, showing efficacy, submission to the Food and Drug Administration for approval. I mentioned that it's an exciting time because the FDA gave approval in June to Atucanamab, not because it improves dementia, but it does reduce amyloid plaques. Now, the different colors here are representing the different strategies of these medications. So the ones in blue colors here are targeting the beta amyloid, the plaque, and some of them the oligomer. And the green one here are targeting tau, the neurofibrillary tangle. And then here in orange are strategies targeting inflammation. Now here's a list of 4 monoclonal antibodies that are directed against beta amyloid. I mentioned Atucanamab, which was approved by the FDA, and Biogen has called it the brand name Aduhelm. There's also Lecanemab, Gantenerumab, and Donanemab. And these all show dramatic reduction of brain amyloid by PET scans, but they are associated with some side effects that we call Arya for the opera, amyloid-related imaging abnormalities. So it's not a home run here. Aducanamab, here's a phase 1b study with 165 persons with mild Alzheimer's or mild cognitive impairment who received an IV infusion of this medication once a month for 1 year. And the infusion dose was gradually increased from 3 to 6 to 10 milligrams per kilogram. And here's the baseline amyloid PET scans with the orange here showing amyloid plaques. And then 1 year later, the placebo group that got an infusion, but just a mimic, normal saline, no Aducanamab, did not show much change in their PET scan. This is just a cartoon because these look pretty similar. They're a little different, I guess. But in a dose-related fashion, higher doses of Aducanamab were successful in removing amyloid plaque from the brain. So this is just a pathology specimen from showing amyloid in the middle here in this maroon color, and the brown is staining the microglia, which are scavenger cells, and the antibody binds to the amyloid, and it sends out signals then to attract the microglia to clean up. You can see they're pretty swollen here. They're eating up the amyloid. Now this up here, and this will result in cleaning up the amyloid PET scan. So that's a significant encouragement. Here at week 54, we're seeing the effects on a dementia rating scale. The higher the bar, the greater the dementia, the worse the memory. And these different bars show different doses of Aducanamab. And so in this phase 1 study, it was hopeful because it seemed that in a dose-related fashion, there was not as much dementia progression in the persons receiving Aducanamab. Now, there were 2 other phase 3 studies, and of course, these 3 studies, the phase 1 and then these 2 phase 3 studies, were evaluated by the FDA. These two phase 3 studies were called Emerge and Engage. And this shows the results of amyloid PET scans with the Atucanamab. You can see that the amyloid is going down in both the phase 3 studies, Emerge and Engage. And this is what happened to the clinical dementia rating scale. Again, going up means dementia is getting worse. And the little dotted line here shows the group that received the antibody. This Emerge study was significant, statistically significant, but the Engage study was not statistically significant. So this is why the FDA did not give full approval to Atucanamab, but an accelerated approval based on the ability to remove beta amyloid. The FDA asked Biogen to conduct a phase 4 study in the real world to follow patients' progression of dementia. I wanted to show you what Arya looks like, amyloid-related imaging abnormalities. On the higher target dose of Atucanamab, which is being marketed as Aduhelm, 10 milligram per kilogram, 35% of 1,100 people developed Arya E, stands for edema. You can see on white here that there is some edema. We talk about edema in the ankles in people who have congestive heart failure. Well, one of the side effects of the antibody is to cause some inflammation of the blood vessel in the brain, which can leak some fluid, just water for the most part, into the brain. And we can see that on MRI. So MRI scans need to be done at baseline before Aduhelm is given at 10 milligrams, and then 6 weeks after Aduhelm is given to see if Arya develops. And if it does, then we have to hold the dose and may or may not give steroids. Here's a patient whose edema went away with steroids. These antibodies can also cause Arya H, hemorrhages, 19%, or hemorrhages on the surface of the brain, outside of the brain, called superficial siderosis. So here's a special MRI scan showing a small little microbleed. These are magnetic field effects from a small amount of bleeding, hemosiderin, iron getting into the brain. And the dark color here is showing the result of some bleeding on the surface vessels of the brain. These are not uncommon. Usually the person does not have serious symptoms, but there is confusion here in 8%. You could also have headache, so we would have to get an MRI then as well. I'll be interested in the discussion to get your feedback on how you would value a medication like these monoclonal antibodies that can remove beta amyloid from the brain pretty clearly, pretty dramatically, but not sure yet will they really help the person's symptoms. Some studies say yes, some studies say no. So it's not a huge effect. It's not a dramatic effect, at least not in 18 months. And there is this medical side effect of Arya. The cost of the Biogen Aduhelm is $56,000 a year. So that's another thing to throw into your equation, the economic decision-making and medical decision-making. And we don't know yet whether CMS is going to cover that. This is a slide from Paul Ezen, who's the director of the USC Alzheimer's Therapeutic and Research Institute. It's physically located in San Diego. I've just gone over a couple of trials for persons who have early symptoms of Alzheimer's disease, mild cognitive impairment, or mild dementia and positive amyloid PET scans. So here are clinical trials in people who are already having mild symptoms over here. And Paul is really interested in prevention, doing the clinical trials when people show positive amyloid in their PET scans, but no symptoms yet. They're cognitively normal. Now, in the last part here, I'm going to just give you a little summary of some of the Alzheimer research going on at the Keck School of Medicine. There's research going on across the University Park campus as well. As Nadine said, I'm one of several co-PIs for the Alzheimer's Disease Research Center. We do clinical research. We're one of 30 centers funded by the National Institute on Aging. On the other end, basic research is done in the Zilka Neurogenetics Institute, which is directed by Dr. Zlokovic. At the Stevens Institute of Neuroimaging and Informatics, Dr. Toga and Thompson are giving us the tools. You saw the PET scans, the MRI scans, and here's an MRI scan showing the white matter connectivity of the brain with the different colors annotating what direction these connections are going. And then Dr. Ezen in the ATRI in San Diego is the hub for a national network of clinical trials for Alzheimer's disease. So USC is really on the map now for leading research in Alzheimer's disease. Here's our website, Brain Health at USC EDU, and here's a number of our clinical research studies that are enrolling patients. Nadine and Rosalva are our key recruiters and retention coordinators. We have a study, many studies on Alzheimer's and also on blood vessels, which are of course important for Arya and also important in diabetes or high blood pressure. We have studies on some of the behavioral symptoms associated with Alzheimer's, like agitation. There's a study on exercise to reduce and prevent dementias. And here there's I'll tell you a little bit more about this online approach to getting people ready to participate in clinical trials. One of the challenges is that it takes a lot of time to recruit people for observational studies or clinical trials. And at the ATRI in San Diego, we're taking this attempt of enrolling people who are cognitively normal, but might have risk factors for Alzheimer's, and want to know if a study is available to prevent Alzheimer's. And so persons might be worried because mom or dad or brother or sister had Alzheimer's, might be concerned because they're carrying an ApoE4 gene, or even more concerned because carrying two ApoE4 genes. So this is a way to get involved early. You can do it from the privacy of your home on your own computer. You start to take some memory tests called Cogstate, and over time, the program will ask you to repeat the test. And the results are analyzed to see if your course is normal for age, because as we get older, we all have changes, slowing. So the computer program will separate out normal aging from something of more concern. And if there is more concern, then they'll recommend coming in for a visit and maybe either a PET scan an amyloid PET scan, a tau PET scan, or maybe a spinal fluid or blood test. And then people would be in this way registered and ready to go into a treatment or prevention trial. Here's a resource for families and also professionals that is sponsored by our funding agency, the National Institute on Aging. So you can go to www.alzheimers.gov. And I want to thank you very much for taking time out today for your interest and attention. Again, there's our website, an email address, and a phone number to call if you're interested in any of our USC research studies. Thank you very much.
Well, we did have one question already in the chat, and I'm sure that there will be others as well. You can put your questions in the chat, or you can raise your hand. But the first question came through from Candace, and she says, what's the protection percentage of cholesterol lowering drugs?
Yeah, the story about statins has been interesting. As I said, I've been in the field 40 years, and first thing came out from epidemiologic studies was that people who had statins on their medication list seemed to have a lower incidence of Alzheimer's disease. So the next step was to put these statins into a clinical trial. And there, the study was negative. Taking statins did not reduce the incidence of Alzheimer's disease in a clinical trial going forward. And then patients come to me, and reading on the internet, they'll even say that I've read that the statins can decrease my memory and cause problems. That's what I mean. I've heard the pendulum switch all the way from it's helping to it's not helping to it's hurting. But I from time to time, I look at the evidence that it's hurting, and I don't see that. So statins are very helpful for slowing atherosclerosis. And that's a huge risk factor for heart attack and brain attack. So statins are very powerful. They can reverse atherosclerosis. What they do for Alzheimer's disease is not clear, but I don't think it's harmful. But again, there's some controversy about it. Even one of my colleagues did a recent review, and found that for women, actually, it might have more of a harmful effect than for men. So that certainly got my antennas up too. But that was a retrospective study now. So more to come. It's a good question.
Do we have any other questions? Because I have plenty. I'm not sure about the people who are on the call. Oh, well, we have another one here. Not on a statin, even though my cholesterol is 222. But you know, you don't know what the combination of that statin, you don't know the combination of your good and your bad cholesterol when you're looking at that overall score. So you need to know the difference between the two.
Yes. So again, it's talking about HDL and LDL cholesterols. And so it's a good question to take to your own primary physician to get the profile. And our decision as physicians about whether to start a statin or not, or based on that profile, we're particularly interested to know if the LDL to HDL ratio is too high, and that's atherogenic. We also want to take into account your own medical history. If you had angina, heart problems, or any strokes, and also your family history. Because if there is more risk in your own history, or your family history of heart disease or stroke, then we want the LDL cholesterol to be like less than 80. So our targets are different. If a person's has a total cholesterol of 220 and an LDL cholesterol of 120 and a family history of heart attack, and we want the LDL to be like 80, then by diet, one can reduce the LDL to maybe 120 to 100, but by diet alone, can't get it down to 80. So then we would say you're going to need both the diet and the exercise and probably a medication. That's how we make the decision.
Mhm. There's a question about, is medication like Arecept helpful to decrease cognitive decline?
Yeah, Arecept, donepezil is one of those drugs we've had for many decades. It does improve symptoms a little bit, but it doesn't change the accumulation of amyloid or tau. So I talk about it as a symptomatic medication, not a disease-modifying medication. And how much does it reduce or improve symptoms? So it's not that great. It's about 1 in 5 people might notice an improvement. Most of the time, we don't notice, but the studies will say that if it's given early on with mild cognitive impairment, that it might hold someone at their current level without the progression for maybe a year to 2 years. So Arecept is mildly beneficial. It has some mild side effects on the gastrointestinal tract. The medication increases the duration of acetylcholine, which is an excitatory chemical message in the brain. That's why we think it's helping symptoms of Alzheimer's, but it also increases peristalsis in the stomach and gastrointestinal. So that's the mild side effect. But if you get the side effects and you stop the medication, then those side effects go away.
Mary says, is the APOE4 blood test common and does Medicare pay for it?
The medical profession still has not been promoting genetic testing of the population for APOE4, even though, as I said, it's the strongest and most prevalent risk factor for Alzheimer's. The test can be done in your home through 23andMe. You can, or through ancestry.com. But then what are you going to do with the information? Right now, we can say exercise more and eat a better diet and do all those modifiable risk factors with more vigor. But we still don't have a good prescription yet for it. One of my colleagues, Hussein Yassin, is pushing higher doses of DHA, fish oils, for people that have APOE4, because he has data showing that the carriers of the APOE4 may not be able to absorb fish oils into the brain as well. The tests can be ordered and paid for by Medicare as well, the APOE4 gene. So the doctor can order it as a medical test. Some of the cost of it used to be, well, in the lab, it costs probably about $30 to do. 23andMe probably charges $100, $120 to do APOE testing, plus other things like for breast cancer and colon cancer. Some of the labs we send APOE for used to cost $200, and now they're charging $400. So it is good that Medicare will pay for some of those tests.
Mm-hmm. Thank you. Karen says, how do you differentiate CTE from Alzheimer's, especially in an individual with an early history of serious concussions unrelated to sports?
Mm-hmm. Yeah, CTE, chronic traumatic encephalopathy. It became kind of a household term with football. And multiple concussions or dings can cause the accumulation of tau, phosphorylated tau in the brain, but not amyloid, interesting. So the tau can start to build up and progress. So that was a wake-up call to me, because when I was in training, I was taught that if you have a brain injury, well, you have an injury and you have some problems, but then you get better and then you're stable. But we've learned that with chronic traumatic encephalopathy, it can be progressive even after there's no further new brain injury. It's progressive, and it's associated with neurofibrillary tangles and tau. So we can see tau positive PET scans, but amyloid would be negative.
Richard was saying, is there any relationship between the gut microbiome and brain health as it relates to AD?
It's another popular research topic now, the microbiome. My colleague, Dr. Zlokovic, is a world expert on the blood-brain barrier. And in the studies that Nadine, Salva, and I are involved in recruiting for, we're looking at the integrity of the blood-brain barrier, and we find that in Alzheimer's, it's actually a little bit leaky. I showed you the Arya, the edema, where there's edema accumulating. Well, Dr. Zlokovic's group is able to show when contrast is given, gadolinium contrast, that there's even smaller leaks. We can't even see it visibly in Alzheimer's. And so in Alzheimer's, there may be some permeability to toxic products from the microbiome in our gut. Normally, our blood and our brain are separated by a tight curtain called the blood-brain barrier. But in Alzheimer's, it might be a little leaky. So what's going on in the gut and circulating in the blood might have greater entry into the brain. It's a topic for research, and NIA is funding that kind of research.
Dr. Yvette Jackson, she says, the testing you mentioned near the end, which reflects that it will prompt one to retake. Oh, is there a link for this?
Yes, that is the web. This one, www.aptwebstudy.org. And then you can, if you have your iPhone handy, you can point your camera and.
Great. Are there tests that most physicians can perform to detect early cognitive decline?
What we use in varies, but we call them screening tests, and it depends how much time the physician has. I will give something called the Montreal Cognitive Assessment Test, MOCA. If you go down to Starbucks and you order a MOCA, it's easy to remember. Montreal Cognitive Assessment takes me about 10 to 12 minutes to give that test. I ask people to remember 5 words and to tell me all the words they can think of, draw some pictures, name some objects, tell me some similarities, things like that. Another common test is called the mini mental state. Dr. Tang and I, my colleague, and I at USC, we modified the mini mental state and called it the 3MS, the modified mini mental state exam. That takes about 10 minutes to give. And if people don't have a high school education, so then I'll pick to give the 3MS test rather than the MOCA. And then I have a colleague, Sue Borson, who's joined the faculty at USC, who's a geriatric psychiatrist, and she has developed the mini cog, which takes like 3 minutes to give. So a physician who's in a very busy practice can at least do the mini cog. Now, these are screening tests, and people who are highly educated, these tests may be a little bit too easy for people who are highly educated. So then we need neuropsych testing, and that takes, at least an hour and a half to give. And we we do that in our clinic after we do the screening test, but find out that someone is really very highly educated, or they were genius or Mensa or something like that. So we have to tailor our tests.
Darlene's comment is, if the gene can be dormant for decades before you experience symptoms, and it's inevitable that you will get the disease, what does a good diet and exercise do for you? And does it just give you a few more months of being cognitive?
Yeah, it's asking, what the different effect sizes are. So if we're talking about an autosomal dominant gene, those genes, like I was talking about the movie Still Alice, or Dr. Alzheimer's young patient, those we say have 100% penetrance. So we're carrying them from birth, from the time we're conceived. We inherited an autosomal dominant gene from mom or dad. But like you said, it's remaining, quote, dormant, or at least subclinical, that we can't see anything until age 40 and the 50, the symptoms appear. And in that case, the effect is so strong that I'm not sure how much exercise or good diet can head that off. It's just kind of too overwhelming. It's like maybe 10-to-1, the effect. But if one has one ApoE4 gene, one probably can have some effects with exercise and diet. And then for some of those other genes that are even milder, maybe we can do more. It's an excellent question, and I don't have specific answers for you, but this is how at least I think about it.
Mm-hmm. Bonnie's asking, if you have ApoE4, is the ApoE3 you also have protective?
Good question. ApoE2 is protective. Unfortunately, only about 1% of us here have ApoE2. It's protective. ApoE3 is kind of in the middle. So if we line them up in terms of which flavor has the greatest risk, 4 has the greatest risk, 2 has the least, it's protective actually, and 3 is in the middle.
Got it. Sorry, everyone, I have to put my mask on because I have students that are coming into the office. If I may request, and I believe that the answer is yes, when we send the follow-up email asking you about this event, we will also provide you with some of the resources, and the web page that highlights Dr. Chui will also be updated with the recording. It'll also go on our USC YouTube channel, but we'll also include, if you would like to share your PowerPoint deck. I don't know, it's pretty complicated without the expert behind it, but any of the resources, any of the studies, all of that kind of thing will be in the body of the email, and we'll also be putting it on the website. And then there are other colleagues that we are partnering with that will have further information and workshops that will follow up on this one. I can't thank you enough. This has just been wonderful, and you've gotten lots of accolades in the chat section. Everybody's saying wonderful, and we just really appreciate it. Nadine has been putting some links in there, but again, we will have that on the follow-up for so that you will be able to have all that information. So, any other further comments you would like to make to all of us?
Well, I want to thank you. I see 78 people on here, and I just wanted to say that we have research studies. We also have memory disorders clinic at Keck, and there's besides myself, there's Dr. John Ringman, Dr. Arus Varpadian, Dr. Elizabeth Joe, Freddie Siegel Gadan, myself, and also Dr. Colin Liu So all of us speak English, some speak Spanish, some Armenian, and some Mandarin, Chinese.
That's terrific. That's wonderful. Well, again, thank you so much. We really appreciate all this good information. It did go up to 81. So, and we had over 90 people RSVP. So that's really an amazing statistic there. So thank you so much. And we look forward to seeing you all again in our next Zoom session. Take care, everybody, and be safe.